sometimes, especially if they leave it open-ended, like, is there any other questions or anything else you would like to share? Or is there anything, maybe if they ask you what a weakness is of yours or time you failed, maybe that's a good time to bring up something that you know may not be seen in the ideal light on the faculty side of things. And it's time for you to clear the air. Maybe it's the fact that your academic performance at one point in your life was not the best, and this is what you've done to overcome it. And that you saw it as a failure back then, but now it's become a strength because you've built a lot of resilience and discipline to make things right and to go the extra mile with stretching your ability to learn and grow, and not seeing it as a failure, but as something that was just something obstacle you had to overcome, and you have, or whatever it may be. Well, hello, future CRNA. So we are in October, which is interview season. So in today's episode, we are going to reveal some clinical style questions with answers, some common questions again that you may get asked in your interview. So that is what this episode is going to be all about. Grab a pen and paper and let's get into the show. All right, welcome back to CRNA School Prep Academy podcast. I'm your host, Jenny Finnell. And again, we're going to cover some clinical style questions with answers. And these questions are all from the CRNA Interview Clinical Question and Answer Study Guide that we have made that has over 88 clinical CRNA interview questions with answers. You can purchase the full guide. I can post the link in the show notes below if you would like to do that. I can't go over the whole 88 questions on this episode. I think it'd probably be about 5 hours long if we did that. But I am going to try to hit some heavy hitters on here for you and cover kind of a nice wide variety. This is going to be kind of an episode that you definitely want to star and re-listen to when you have a piece of paper and pen handy. If you're driving, doing laundry, I got you. Don't worry. I am commonly listen to podcasts when I'm also multitasking. So it's going to be a great episode for you to listen to nonetheless. But I do think if you're able to take notes, you're going to be a little more well served long-term from this episode. So again, if you are interested at the end of this episode to purchase the whole guide to prepare you for your upcoming interview, you can do so. I will post the link in the show notes below. And I want to wish you the best of luck on your upcoming interview. I know you're probably like, Jenny, I'm freaking out. Totally get it. But congratulations, because the fact that you got an interview means that you're qualified for acceptance. You know, they saw potential in you. So you have to now believe in your own potential. So try to get the mindset right. And, look at it as this is an opportunity for to learn and grow, to see what this is like. All CRNA schools are a little different as far as the style of interview. Not all schools will even ask you clinical style interview questions. So if that is you, while I still think this episode is going to be incredibly valuable, especially long-term, as you start your CRNA journey, know that not all schools are going to ask you pathophysiology pharmacology questions. And so while I think you should not neglect that knowledge base, because there's always a potential, I do think, you should understand the style you're getting ready to go into. And if they're going to ask you more personal questions, maybe at the end, I can cover some common personal questions and just different tidbits on how to answer those. I'll just wing it because I don't have that in the study guide, but again, I don't want to leave you out if you're going to be having, or if you're getting ready to experience a very heavy personal interview. So at the end of the episode, again, I'll cover some common personal questions that you may get asked and just some of the different variations and personal questions that I have heard throughout the years of mentoring students. So without further ado, let's go ahead and get into it. All right. So first, we are going to cover the question, please explain the difference between SaO2 and PaO2. So the SaO2 is the percentage of hemoglobin binding sites that are occupied with O2, oxygen. The PaO2 is the pressure exerted by the oxygen, O2, on the arterial wall. So your PaO2, or your pressure, is measured in millimeters of mercury. All right. And the adult normal is within a range of 80 to 100. So the normal PaO2 in an adult is 80 to 100 millimeters of mercury. I want to emphasize the unit of measurement, millimeters of mercury, because if you just start rambling, if they ask you some type of clinical question and you rattle out a number, they may come back and say, in what unit of measurement? And if you haven't quite paid attention to that, you could be like, oh, darn it. I knew the number, but I didn't remember the unit of measurement. So again, to have a fully correct answer, you need to remember the unit of measurement. All right. So the PO2 again is measured as millimeters of mercury. Normal is 80 to 100 millimeters of mercury, and the SaO2 is measured as a percentage. The normal adult percentage is right around 90 to 100% SaO2. The PaO2 requires an arterial blood sample, while an SaO2 can be acquired by placing a non-invasive sensor on the skin, aka the pulse oximeter. So note here that oxygen saturation, the SaO2, does not differentiate between oxygen or carbon monoxide, as they both bind to hemoglobin. So again, you can have carbon monoxide poisoning, and on your pulse oximeter, you could be registering 100% O2. And you're like, oh, I don't know why you look so blue, sir. But just know that unfortunately, the pulse oximeter doesn't differentiate between the two. That could be a little curveball they throw you potentially. All right, so let's move on to the next question. What is the difference between hypoxia and hypoxemia? All right, so the definition of hypoxia is low levels of oxygen in body tissues. So I'm going to say that again. Hypoxia is low levels of oxygen in the body tissues, where hypoxemia, the emia, means blood. So hypoxemia means low levels of oxygen in the blood. So again, relatively basic, but the emia is really the differentiating factor that really can maybe trigger your brain to kind of differentiate the two. All right, we're moving on. Go ahead and tell me about the pathophysiology of ARDS, which is the adult respiratory distress syndrome. So ARDS is actually very complicated, and there's actually probably more to it on here, but I kind of explain it in 3 stages to make it easier. Now, keep in mind, if they ask you about ARDS, this could lead into then explain sepsis, right? Because again, they kind of go hand in hand, but ARDS is a special type of sepsis, right? So just make sure you're differentiating between the two and not blending them together. And if they have you explain the difference, be able to do so. But let's go into the 3 stages of ARDS, which is exudative, which is essentially damage to the alveolar epithelium and the vascular endothelium, which causes it to produce leakage of water. Okay, so your lungs can then fill with that leakage. The leakage of water, it also leaks protein and different inflammatory mediators, red blood cells, again, into the interstitium and the alveolar lumen. So kind of filling your alveolar sacs with fluid and different types of inflammatory mediators, red blood cells, protein, etc. Type 1 alveolar cells are irreversibly damaged, and that space is replaced by the deposition of the proteins, fibrin, and cellular debris, producing hyaline membranes, while injury to the surfactant producing type 2 cells contributes to alveolar collapse. So there's 2 different types of damage going on. They're damaging type 1 alveolar cells, which are irreversibly damaged. And again, that space is then replaced by, the proteins, the fibrin, cellular debris. And again, there's also injury to the surfactant producing type 2 cells, which then cause the alveolar to collapse. So you may know surfactant in infants. That's why preemie babies get steroids to try to start producing that surfactant, because otherwise their lungs very easily collapse and they get really severe atelectasis, and there's pneumonia and things of that nature that can, and obviously hypoxia and things of that nature that can happen from atelectasis. So again, ARDS is a situation where that is actually occurring, and not only are you filling up the alveolar with, again, the fluid and different types of inflammatory mediators, but you're also damaging the type 2 surfactant producing cells, which then unfortunately allows the alveolar to just easily collapse and not remain open. So patients who have ARDS, you'll see them on very high levels of PEEP. to try to combat the lack of surfactant and the collapse of the alveolar cells. All right, then you have that's the exudative phase. Then you have the proliferative phase. I can't even speak, which is again where the type 2 cells proliferate with some epithelial cell regeneration, which kind of can cause a fibroblastic reaction and remodeling. So, and then you have the very last, the third stage, which is fibrotic, which involves collagen deposition in the alveolar vascular and interstitial beds with development of microcysts. So, kind of really painting a really grim picture here, but it just kind of self festers into being a very damaging process to your lungs where very little healthy lung is left, if any. And it's incredibly hard to get a patient to recover from this because it kind of creates this really vicious cycle that just severely damages the cells to the point where they're of no return. So those are the 3 stages of ARDS. Obviously, ARDS, the sooner you intervene and correct the underlying cause, the better the outcome will be. If you get to the state, second and third phase, there's not, the outcomes are probably going to be relatively poor. Okay, so what are some optimal vent settings then for ARDS, they may ask? Well, low tidal volume, between 4 to 6 mLs per kilo to prevent like barotrauma or volume trauma. So again, the alveoli are really sensitive because they're already maxed with like pus and fluid, and their surfactants damaged. They don't have much elasticity anymore. So if you're blowing large tidal volumes in there, you're just going to further damage the cells. With like barotrauma, they're very sensitive to that. So they typically do low volume, and again, keep their airway pressures low because they're going to be unnaturally high because again, of the alveolar, again, having the lack of surfactant and being full of fluid and things of that nature. You want to really watch your plateau pressures. You always want to try to aim to keep that below 30 centimeters of water. So again, you want, low tidal volumes, probably higher respiratory rates, and you want to really watch your airway pressures to keep your plateau pressure under 30 centimeters of water. All right, so that is ARDS. And again, keep in mind they could lead into sepsis from there. And again, the pathophysiology of sepsis is pretty complicated, but I do go into that in some of the next questions. So that is in this guide. I'm going to kind of jump ahead a little bit to, let's see, let's go into some numbers, some cardiac numbers. That's always a good one. All right, so what are the normal values and how to calculate of the following? So they could give you one of these, they could give you several of these. You may have a written test that has this on it. It could really just vary of the format they could ask you these types of questions. But again, these are all good formulas to put in that memory bank of yours. Okay, so first would be the coronary perfusion pressure, the CPP. So coronary perfusion pressure. We also, and I'll go right into that one instead of going further, but coronary perfusion pressure is your diastolic blood pressure minus the wedge pressure. Okay. And kind of understanding what the normal wedge pressure is really kind of key too, to kind of know where you're going to fall in this range for the coronary perfusion pressure. However, normal coronary perfusion pressure will fall between 4 to 12 millimeters of mercury. And again, the millimeters of mercury is important to know as the unit of measurement. So again, I'll say it one more time. Coronary perfusion pressure is your diastolic blood pressure minus your wedge pressure. Okay. So, to get a wedge pressure, obviously needing a swan for that. If you have just a PA catheter, maybe you're not wedging it, to get that number. You can always look at your diastolic of your PA pressures, and it will be relatively in line with what your wedge pressure will be. That was kind of a little bit of a hack or a trick that we would use and when I did open heart, if I didn't want to wedge it or kind of see, that was kind of it was pretty relatively in line with what your wedge pressure would be. So just a little hack there. Not that would be important for this, but I just figured I'd share it since it's on my mind. All right, let's go into another one of these. I want to share ones that are more common. So normal cardiac output. So they may just say, what's the normal cardiac output? which is 4 to 8, what? 4 to 8 liters per minute. So again, knowing liters per minute is really key. If you just said 4 to 8, they may be like, well, 4 to 8 what? So knowing that it's liters per minute, I think is kind of the big takeaway here. Another one that would be good to know would be normal cardiac index. Now, your cardiac index is your cardiac output divided by your body surface area. And they may then go into what's the body surface area formula, right? So, or cardiac output formula. So make sure that, again, when they're asking you these types of questions, that they could dig into it more. So you kind of have to go deep with how many formulas you know and break down. But if they ask you what the cardiac index, what normal cardiac index would be, if you were to, if you were a nurse who had experience with swans and things of that nature, you probably would know. But they may, if maybe you're a neuro nurse and maybe they want to throw you a curveball and they ask you this too. I've heard of that type of situation occurring. So the normal cardiac index is 2.5 to 4 liters a minute per meter squared. So keep in mind it's liters per minute per meter squared. Okay. So again, the extra unit of measurements on there at the end that I think would be very important for you to mention to get a fully correct answer. One that I think is really common is the MAP. How do you calculate MAP? Calculating MAP is your diastolic pressure. And then what you do is you take your you take your systolic pressure minus your diastolic pressure. And then, you divide it, you take 1/3 and you divide it by that. So again, your diastolic blood pressure plus your systolic blood pressure minus your diastolic pressure divided by 3. And the normal MAP is usually greater than 65. But they could just give you, okay, your patient's systolic is, 150, your diastolic is 95. Tell me what their MAP is. And they could have you just calculate it out in your head like that. So keep in mind that could be fair game. So I definitely would practice this. I wouldn't just memorize these formulas. I would actually practice calculating maps and calculating different formulas. So that way, if they just give you some numbers, you can go ahead and do that. And they may give you a piece of paper and a pencil and at least let you write it out. But some of them may want you to try to do it in your head. So again, it's important to not only know these formulas, but actually practice doing the formulas. And it will help you memorize the formulas too, honestly. So I think it's a good practice either way. Let's do your cerebral perfusion pressure. That can be confusing because coronary perfusion pressure, CPP, they're both CPP. So if they say, tell me what CPP is, which I doubt they will, but you'd have to say, are you talking about coronary perfusion pressure or cerebral perfusion pressure? But cerebral perfusion pressure is your MAP. So your just like the MAP formula just went over, your mean arterial pressure minus your ICP. So they could potentially give you a blood pressure, give you an ICP, and say, okay, go ahead and calculate the cerebral perfusion pressure. And so first you'd have to calculate the MAP, then you'd have to minus it from your ICP, and then tell them if that's a normal range or not. So normal cerebral perfusion pressure is between 60 and 80 millimeters of mercury. So these are just examples of different situations you could find yourself in if they have you calculating different types of formulas like this. Be ready and prepared to work them out for different situations. All right, we're going to jump ahead again. Let's go into, those are a bunch of arrhythmias. Would be easier to study with visuals, but I do have arrhythmias on here. You should be able to identify arrhythmias. I have some airway structures on here to label. This one's I like this question. What EKG lead is used to monitor for arrhythmias? Usually it's lead 2 is the one that is the most common on the EKG to monitor arrhythmias. You'll always, like if you look at your EKG next time you're at work, see what EKGs are automatically populated on your monitor. You'll usually always see lead 2 as one of the leads. Because again, it's the best one to pick up for arrhythmias. What EKG lead is used to monitor for ischemia in the left ventricle? So very specific, right? Now, if you have all the EKG leads and their placements memorized, you probably pretty quickly know that it's V5. But again, maybe you don't know. So this might be a key area for you to kind of brush up on. But again, to monitor for ischemia in the left ventricle, you're looking at V5 is the EKG lead that you want to be looking at. All right, we're going to jump ahead again. What does inferior mean when talking inferior wall in the heart? So inferior myocardial tissue is supplied by the right, the RCA, the right coronary artery. Okay, so the RCA supplies the inferior myocardial tissue. So the inferior wall refers to the underside of the left ventricle. All right. Where are the carotid arteries? They could actually give you a picture of the heart and have you label it. So that is another good thing that you should be practicing. Again, you can do that. I have an unlabeled picture of a heart here that you can practice. But if they just ask you where are the carotid arteries, they are located on both sides of the neck that supply blood to the brain, face, and neck. Again, you need to learn the branches off the aorta, which is the brachiocephalic trunk, and the subclavian arteries. But again, if you look at the aorta and the different branches, again, I encourage you to review that. So if they have you identify whether that be a fill-in or I don't know how else I'd have you do it. Probably would be a fill-in. You can accurately identify those branches. All right, let's go into what are some things that could increase ICP? Tumor, subarachnoid hemorrhage, intravascular hemorrhage, subdural hematoma, stroke, aneurysm, hypertension, infection, meningitis, or encephalitis, increased cerebral spinal fluid, head trauma resulting in bleeding and swelling of the brain, hydrocephalus, Valsalva maneuvers, which I think is really interesting, coughing, suctioning, noxious stimuli, seizure activity, and lowering the head of the bed. So gravity, increasing blood pressure. But yeah, they could ask you. And again, if you don't name all those, I wouldn't beat yourself up if you got asked that type of question. But knowing a good chunk of those would be good to know. These ones I think are pretty. This has been asked more than once at a particular school. I don't know if a lot of schools ask this question, but it definitely comes up at least at some CRNA school interviews. So I'm going to go ahead and mention it here. Why does renal failure cause anemia? I would think if you weren't a MICU nurse, you may not even, renal failure causes all kinds of like chain effects from renal failure, but you will always see anemic renal failure patients. And there's a reason for it. It's because erythropoietin, EPO, it's abbreviated. So erythropoietin is produced in the kidneys, and it's the hormone responsible for signaling bone marrow to produce red blood cells. I was actually asked in my interview where red blood cells were produced. And I said, liver. Yeah, that was wrong. It was bone marrow, but I questioned it. And that's why I was like, I said it's so funny, but it was like definitely a rapid fire type of question. But yeah, they didn't ask me about erythropoietin, but they did ask me where red blood cells were made in the body. So that is the bone marrow. So anyways, chronic kidney disease results in decreased production of erythropoietin, causing the anemia. All right. Which blood component is more likely to cause infection and why? So when you're giving blood, what blood component is more likely to cause infection and why? The answer would be platelets. And it's because they have a high leukocyte content within the platelets. So they result in the highest rates of transfusion transmitted infection. And also, where are platelets made? Bone marrow. A daily dose of inspiration from a CRNA School Prep Academy student. I have been waiting to write this post for a few years now, 3 to be exact. I finally got accepted to CRNA school. Thank you so much to CSBA for everything. I have been a member for 3 years and went to 2 conferences, which was super helpful. I also did 2 mock interviews. I then did the 5-day interview boot camp 3 separate times as well. Here's my story. This has been a lifelong dream of mine since I was 13 years old. My GPA was a 3.2, so not the best, and I refused to take the GRE because I don't feel standardized tests should be used to determine the quality level of a student. I worked at a busy level 1 trauma center for 6 years and was a part of every committee possible. I also had my CCRN, my TNCC. I was charge nurse and a preceptor. I took grad level biochemistry course from Oregon State as well. I applied to over 7 different schools and only got 2 interviews. Rejection was not fun over and over again, and after a failed interview in January, I almost gave up. CSBA helped me so much and gave me the motivation to keep pursuing my dreams. Moral of the story, do not give up. I just love this story so very much. So, dear future CRNA, you know who you are. Congratulations. I'm so incredibly proud of you. If you're not already subscribed to our free Future CRNA newsletter, be sure to do so now. Pause this episode and click the link in the show notes or comments below. Cheers to your future. Now back to the show. All right, we're going to jump ahead again. We're going to wrap this up here. Those ones are so knowing like the normal range for ABG, I would think it'd be a relatively standard thing that you should be knowing going into your interview. I also think you should be studying ABGs in general and kind of being able to identify what type of ABG they are. So whether they're metabolic, respiratory, whether they're compensated, uncompensated, that type of thing. Make sure you're practicing your ABGs. There's an entire ABG lecture inside of CRNA School Prep Academy. For those of you who are in the Guarantee program, we had a very special guest lecturer, Nicole Kupchak, come and give you guys a great presentation on CO2 as well, which I know it's kind of random. We're talking about ABGs, but she's so good at explaining capnography. So really, it's a really great piece of information for you to gather. I really would encourage you to rewatch that lecture, but also don't forget to review the ABG lecture that CRNA School Prep Academy provides you as well. Because again, it's a very, and this, you would have access to the ABG lecture regardless of being a Guarantee student or not. It's in the Critical Care Learning Library. But I wanted to point out for the Guarantee students who are listening that you also have access to that really special capnography lecture that I think is also would be really good to listen to before your interviews. All right, let's cover what is the oxyhemoglobin curve and how does this affect the O2 affinity to hemoglobin? All right, so shift to the right versus a shift to the left of the oxyhemoglobin curve. So when the curve shifts to the left, when hemoglobin actually hangs onto or holds on to O2. This occurs again in alkalosis. So with low PCO2, again, because PCO2 itself is an acid. So with low PCO2 or hyperventilation, you're going to have low PCO2 and alkalosis. You're going to have a left shift, which is where your hemoglobin is going to hang onto that O2. It can also be caused by hypothermia, low 2,3 DPG. Remember that one? That's found in your blood. These conditions result in higher SaO2, but the tissues do not get adequate O2 readily. So remember how there's a difference between hypoxia and hypoxemia. So again, even though your SaO2 will read high, your tissues have hypoxemia, okay? Because your hemoglobin's holding on to that O2. It's not dispersing it to the tissues. So equally, a left shift is pretty bad. Again, you're hypoxemic, your tissues are lacking adequate oxygenation. Now, the opposite occurs in a right shift. So when you shift to the right on the oxyhemoglobin curve, again, your hemoglobin releases O2 to the tissues very readily. It doesn't hold on to it, okay? This occurs in acidosis with high PaCO2, so hypoventilation, fever, high 2,3 DPG. Again, these conditions result in somewhat lower SA2, but tissues get O2 readily. All right. So again, less O2 for transport to all the tissues. So again, but it just lets go of it so quickly that the hemoglobin then is void of oxygen. So certain parts of your body don't get oxygen because it's already been let go of. So think of it like as oxygen travels through all your body, it gets pumped out of your heart. If you have a shift to the right, your hemoglobin is readily releasing that oxygen right away. So by the time it makes it to some of your other organs, like kidneys, for example, where again, when you're in a septic type kind of state, not only do you get vasoconstriction, but again, your blood by the time it gets there is very void of oxygen kind of thing. So again, in certain conditions, acidosis can lead to peripheral ischemia, right? Where you don't deliver the oxygen because you have limited carrying capacity of the oxygen through your body. So they're both complex, but trying to kind of get your brain straight around them. If they ask you about it, because it can get confusing. I think that's a really great thing to study up on. All right, let's go into one of the last questions here. See if I can find a good one for the last question. All right, we'll go. I like this one. People often ask about, or, ask questions about the autonomic nervous system or find it challenging. It is challenging to learn about the autonomic nervous system. So, what is the autonomic nervous system? Sympathetic versus parasympathetic. So your sympathetic, think of things like fight or flight. You dilate your pupils. You inhibit the saliva because you don't want to eat if you're going to fight a bear. You just want to run. Increase your heartbeat. You relax your airways so you can breathe and run. You inhibit the GI activity. Again, your gut motility slows down. Think of like trauma patients who come in. They always say they're a full stomach because, again, their GI activity shuts down because their body goes into this sympathetic surge. Inhibits your gallbladder. Again, you're not going to be digesting anything because you don't care. You just want to survive. You secrete epinephrine and norepinephrine, and you relax your bladder. So again, those are things that happen during the sympathetic surge. And the relaxing bladder sounds kind of weird, but actually when you when you urinate, you actually contract your bladder. So it's like, even though it sounds like, oh, relax your bladder, doesn't mean you pee yourself. I mean, maybe you will. I don't know. Maybe you pee yourself initially when you see the grizzly bear, and then you just stop. I don't know. But relaxing actually has the opposite effect where you don't have the urge to pee. All right. Then we look at parasympathetic, where you get constricted pupils. Think of being sleepy and tired. You don't care what you have to look at. You just want to close your eyes. Stimulate saliva because you're hungry. You want to eat like that comfort food. You have a low heartbeat. You have constricted airways because you're only yawning at this point. You're not actually trying to breathe really fast. You're stimulating your GI activity to digest that food, rest and digest. You're stimulating your gallbladder for the same reason, to produce the insulin and all those, or start stimulating your pancreas to produce insulin and all those good things. And then you contract your bladder. So again, you go to sleep at night, you just have to pee a million times if you're like me. Anyway, so that kind of just gives you a brief overview. And this next one I think is pretty cool. You are a pilot operating the autonomic nervous system. What drugs would you give to activate the sympathetic nervous system and the parasympathetic nervous system? And what drugs would you give to antagonize both systems? So let's start here. The sympathetic nervous system, as an agonist, you're looking at things that are stimulating the sympathetic nervous system now, such as epinephrine, norepinephrine, and dopamine. Sympathetic nervous system antagonists, ones that are blocking the sympathetic outflow. You're looking at things like beta blockers and alpha blockers. Then you have your parasympathetic nervous system agonists, what's stimulating your parasympathetic. You have your muscarinic agonists, such as, I don't even know what these, let's see, pilocarpine, methylchlorine, things that you typically probably wouldn't give. But anyway, they're muscarinic agonists. And then you have the acetylcholinesterase inhibitors, again, that also work to agonize the parasympathetic nervous system. So they cause stimulation. And then for parasympathetic nervous system antagonists, ones that block the parasympathetic nervous system, you have things like atropine. So again, what does atropine do? Atropine doesn't cause bradycardia. Atropine causes tachycardia. So again, it's stopping the parasympathetic and allowing your heart rate to go, woo, really high. All right. So I think that was pretty cool. All right. And then what are the receptors associated with the sympathetic system? You're looking at alpha, beta, and dopa. All right. So let's kind of quickly cover some emotional intelligence type kind of questions. Some of the most common questions that I think you're going to get as far as personality questions go could be things like dealing with conflict, or what do you see that is potentially a negative, like what's a weakness, right? But they may not ask it that way. Instead of saying, tell me about a weakness of yours, they may say, what would your coworker say about you that they don't like about you? Which puts it in a different, uglier frame, which sometimes can trip people up a little bit, because they're like I know what I'd say about myself, but I have no idea what my coworker would say. And it kind of can throw them off a little bit. So be prepared for that. Similarly, they can ask you about a time you had a conflict with a coworker, or maybe you had a challenging situation with a patient and family member, and how did you handle that? This is why it's good to be documenting these experiences. Obviously, not violating HIPAA of any kind, but when you have a challenging day or a challenging case, document it, write it down, because you'd be surprised at how like muddy the waters get the longer time goes and trying to remember the nitty gritty details. So if you have these experiences in the ICU leading up to your interview, make sure you're documenting it and having make sure you're giving them an ending. There is something called the STAR method, which stands for situation, task, action, result. I'm glad I remembered that. So the STAR method, it just, if you focus on using the STAR method while you're telling a story or about a clinical scenario, it allows you to kind of give a very concrete, to the point example that makes sure you have a conclusion, your result, right? I think a lot of times people get so wrapped up in the details, by the time they either lose them by the time they get to the result, or they leave kind of a cliffhanger because, they got so drawn out on like all the details. Just give a real specific situation, task, the action, and the result that you got from it. And if you stick with that type of method, telling stories will be a much easier task. So that's really common for them to ask you about a situational type kind of question, something that you dealt with, asking you for perspective on what others think about you, what your negatives would be, or what your positives would be. They could also kind of throw you a complete curveball. I've had some students report questions such as, how many golf balls would fit on a school bus? Like just those random questions. Or if you could be any kind of kitchen appliance, what would you be? Or if you could be any animal, what would you be? And it seems totally random, but the importance of these questions is really just to see if you can think on your toes when you get a random question like that, and to give them not only an example, but a reason why. Like, why would you be that animal? Why would you be that kitchen appliance? And so, I mean, who knows? Those ones are definitely more rare. They do still occur. I mean, I've heard some questions like, what would you do if you flunked out of CRNA school? Like I've had students tell me they've been asked that, and it's like, who? Like, so just to kind of throw you off, to throw you a curveball, to see, like, I'm going to put you on the hot seat and under pressure and with a very uncomfortable question for you to answer. Equally in my own interview, I was told, well, what if I tell you that we've already made our decision, we're not going to select you. How would you handle that? Like and that was a question I, again, had to answer in my own interview. And very commonly, I think programs will say, unfortunately, we're not able to select you. You're not going to be able to go forward, but what would you plan to do, over this next year if you weren't selected, or something like that, or the fact that you weren't selected. And again, you have to give them the rationale, like, what would you do, and that kind of thing. So kind of a downer, right? So kind of a downer, but they kind of want to see, like, you're going to get really upset? Are you going to get defensive? Make sure you're keeping jokes to a minimum. If you're a real funny person, cool. I wish, I'm envious. I wish I had some funny bone in me, but I'm the kind of person who doesn't understand jokes. So I usually laugh awkwardly because I don't understand the punchline, which is also equally kind of amusing sometimes. But just be careful, make sure things are appropriate. Read the room. If the tone of the room is very serious, then I'd probably stay serious versus trying to crack some jokes. I had a girlfriend of mine. That's kind of how she handles stress, is she cracks jokes and she giggles a lot. And I love her to death. By the way, she's a CRNA now. But that being said, under pressure, she completely gets this, always making light of something or giggling and joking. And I think they took that the wrong way. In several of her interviews, she did have to interview several times before she got into CRNA school. And so that's not a big deal, but just try to check it, try to keep it in check and in line, I should say, for your actual interview, and be aware of these little nuances. I've done interviews with students who get really nervous and they click their pen and they don't even know they're doing it. And it's so distracting for the person asking you questions. Or I've interviewed someone who, I don't know why. If I was nervous, I would not want to do this. I would feel super awkward if I was nervous to sit like this, but they were literally, if you're on YouTube, you can see me. If you're on the podcast, I'm kind of slunched back on my chair with my arm around the edge of the chair, just kind of like I'm chilling, like I'm at a campfire or a bonfire. Don't do that. Keep it professional, keep your, hands crossed on the table, hips square in front of you. It'll give you shoulders back. It'll give you the most professional look versus being slunched over or anything other than that. Because again, they're assessing body language too. These emotional intelligence style interviews, they're typically also heavily looking at body language. They all do that. but they're assessing for, things like that you may not even be aware of. As far as actual other questions go, a lot of times I've heard student or programs tell me that they do a really great job on their interview. And we get to the very end of the interview and we say, why, do you have any other questions? Do you have any questions for us? And they just say, no, I don't have any questions. And I think they like to see students who have put some thought into some unique questions. It kind of shows that, they've done a little more thorough research and diving and digging essentially to kind of want to know more. That can be hard because sometimes these schools give you this pre-interview open house experience where they answer all the common questions and you're like, oh, that was like everything I thought of. So sometimes your questions have to be a little bit more unique to be able to combat that. You definitely don't want to ask a question that they covered in the previous open house that you just went through prior to your interview, or something they very openly discussed on their website, because that could paint a picture that you're not paying attention. So you do have to be kind of thoughtful when you think of questions to ask them. I've had programs tell me similar things where they get to the very end of the interview and they say things like, it's between you and one other student. Why should we pick you? And they have nothing to say. Like, they don't have any reason to pick them over someone else, which I get is kind of an awkward position to be put in, but to have nothing to say, it's like you're just like throwing yourself right under the bus. So, why would they pick you? You should have a reason that why you would thrive in their program and what makes you special, what makes you unique. Don't be afraid to embellish. Don't be afraid to brag. They are saying brag about you. I'm asking you to brag about you. Why would we want you? Have something thoughtful to say. So that's really common. Trying to think what else. Why this program? That's another one that's also often asked too. If you have nothing that you have thought through other than, the cost of the program is in my budget or the location's great, it's kind of like, wah, wah, wah. Like, have a reason. Maybe the cohorts are small. Maybe, the faculty have been recognized for something that's really important to you. Maybe they provide independent CRNA practice for your clinical rotations, or maybe, have something a little more robust. It's okay if it's location and money. It's okay, but just don't let that be your only why you pick the program. Have it be something a little bit more meaningful to the actual faculty, to help you kind of show that you've put a little more thought into it other than cost and location. Other difficult questions, again, they like to ask clinical style questions as far as, tell me about a time you had a difficult clinical situation. How did you handle it? Um, what would be, tell me about a time that you had a big failure in your life is another one too. What do you see as a failure? Some people are like, well, I really don't think I've really had any failures, but the reality is you probably have something that felt hard for you at some point. But even if you get to the point where you're like, man, I really don't have like anything, Jenny, I have no idea. Well, maybe ask around, ask one of your closest friends, ask your mother, your sister, your brother, like, is there a time that I got really emotionally upset over something, or that you felt that maybe I was, because I can't think of anything that I felt like I failed at. It's like, do you have anything, that insight on me that you think that you would see that I felt that way? Cause I don't know. Sometimes you block out stressful things. Sometimes you move on from them where you're like, oh, I didn't even think about that, but you're right. I guess that was a big deal to me at the time. It isn't now anymore, but I completely blocked that out. So getting insight from friends and family can be an easy way to kind of bring that to light. Have a thoughtful answer for that, and what you did about it, what you've done about it, what you're still doing about it. And then another thing I think is important too, even if they don't ask you, they may ask, because again, if you have something on your transcripts or resume, maybe you're not current in ICU, something like that they think is a big deal, or you're not, you're in the wrong unit, you're not in a preferred unit, you're in the ER, for example, they may ask you like kind of harshly, like, why did you choose not to get true ICU experience and get and go to the ER instead? Or why are you not current in ICU? I had someone tell me that on their interview, they were asked this, they were doing great for the whole interview. And they got this one question where they said, tell me why we should pick you when you're the only applicant we're interviewing who's not current in the ICU. Ooh, that'd be really hard to answer. Ouch. But maybe think that through. If that's you, if you're not current in the ICU, why? And what would you say if they kind of confronted that? Sometimes especially if they leave it open-ended. Like, is there any other questions or anything else you would like to share? Or is there anything, maybe if they ask you what a weakness is of yours or a time you failed, maybe that's a good time to bring up something that you know may not be seen in the ideal light on the faculty side of things. And it's time for you to clear the air. Maybe it's the fact that your academic performance at one point in your life was not the best, and this is what you've done to overcome it. And that you saw it as a failure back then, but now it's become a strength because you've built a lot of resilience and discipline to make things right and to go the extra mile with stretching your ability to learn and grow, and not seeing it as a failure, but as something that was just something obstacle you had to overcome, and you have, or whatever it may be. It might be a time to clear the air. Like I said, it could be a good time, because otherwise, if you don't, and it's, you don't always get the opportunity to do this, they're going to make assumptions. Humans do. That's just what humans do. So it's almost better to like address the elephant in the room, for example, versus ignoring it. And that way you can make sure you're both on the same page, or whatever it may be. All right. Well, I hope that last end of the podcast helped give you some ideas on some personal type questions I could ask. All schools are a little different. Some do a blended clinical with some personal. Some do mostly personal, while others mostly do clinical. Some, I would say the majority of schools are, it seems to be trending anyway, a lot towards emotional intelligence style test. I know a lot of schools will even have you take like a emotional style test before you even come in for the interview, and they have your scores. So they can evaluate your scores. So when it wouldn't hurt, there's a quiz that I always recommend. It's just insightful personality quiz called 16 Personalities. I think it's free. So that's why I recommend it a lot. It gives you some insight onto your character and kind of makes you work. And it's very accurate as long as you don't select neutral. If you select neutral, it has nothing to go by. So stick to one side or the other when you're answering the questions. It'll help give you more accurate results. So again, that's 16 Personalities. I think it's a great free resource for you to kind of help get more insight onto who you are as a person, to allow you to hopefully come into your interview well prepared and well thought through for some of these personal questions. I almost forgot to share something really important with you, which is that if you have not already, you can have access to doing mock interviews with current SRNAs from various different programs through Teach RN, or Nurses Teach Nurses. I don't know at the time of airing this episode whether or not we're going to get around to changing the website or not. More than likely, probably not. But if you go to www.nursesteachnurses.com, again, soon to be Teach RN, you can book a mock interview through that website. We have always posted that link in the show notes, so you can, again, go ahead and book your CRNA school mock interview. There are a lot of different students to pick from. You can read through testimonials for previous students who have had mock interviews. So it's a really great resource for you. Again, getting a mock interview by a student who has recently been through a CRNA interview process is an incredibly great way to practice for your interview. So I hope you take us up on that resource. All right. Well, you all take care, and best of luck. Keep me posted. I love celebrating with you. And even you guys, whatever happens, happens. I know you're probably like worried beyond belief, but this is not the end. This is only the beginning. Okay. Keep your chin up, keep going. Plenty of us have had no before we got a yes, including myself. So it'll be okay. All right. Well, cheers to your future, and I'll see you next month. All right. Bye-bye. Hey, future CRNA. As always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.